A term polyp is a macroscopic descriptive term referring to a localized elevation of the mucosa into the lumen of the organ. It can be classified as neoplastic or non-neoplastic. In this video, we will focus on neoplastic intestinal polyps. They are commonly represented by conventional and serrated adenomas. Serrated adenomas, together with hyperplastic polyps, represent one common group of so-called serrated polyps or lesions. Also, a broad range of other benign and malignant tumors may grow in polypoid fashion as well. For example, adenocarcinomas, lymphomas, or neuroendocrine tumors. Last but not least, we will discuss mural polyps, which are elevations caused by lesions situated in deeper layers of the wall of the bowel. Conventional adenomas represent the most common type of the neoplastic intestinal mucosa polyps. All of the conventional adenomas are defined by presence of dysplasia, which is necessary for the diagnosis. In fact, they are a polypoid form of dysplasia, intraepithelial neoplasia, and they pose a risk of malignant transformation which depends on size of the tumor, presence of a villus component, and grade of dysplasia. Dysplasia used to be assessed by a 3-tier grading system as mild, moderate, and severe. But due to high interpersonal variability, a 2-tier grading system was applied. Therefore, we grade dysplasia as low grade and high grade in these days. Conventional adenomas are usually sporadic and affect older adult patients. They may arise also in setting of hereditary polyposis syndromes, especially familial adenomatous polyposis. In this case, they can be numerous and reach a number of several hundreds. On gross examination, they may be solitary or multiple, of various proportions. Microscopically, as stated before, presence of dysplasia is necessary. It's characterized by depletion of mucus production, elongated and irregular hyperchromatic nuclei, which may even reach the apical pole of enterocytes. Mitosis are more frequent as well. The most common subtype of the conventional adenoma is a tubular adenoma. It's usually smaller and pedunculated. Histologically, it's formed by closely packed epithelial tubules, corresponding to elongated intestinal crypts. A villus adenoma is the less common. It's larger, sessile, with a villus architecture forming long, thin mucosal prominences, resembling villi of the small intestine. It's often localized in right-sided colon. Large villus adenomas may cause a mineral disturbance, especially hypokalemia, due to loss of water and electrolytes. A tubular villus adenoma is a mixture of both previous subtypes. In the microscopical picture, we can appreciate a combination of shorter crypts, representing a tubular component, and long, thin villi. In case of invasion of dysplastic epithelia through basement membrane into lamina propria, we use a term intramucosal adenocarcinoma. Such malignant transformation of the adenoma is characterized not only by invasive growth, but also by architectonical changes of the glands with formation of cribriform structures and desmoplastic stromal reaction. In the picture, there is a fragment of tubular villus adenoma. In this region, the tumor shows high-grade dysplasia with loss of polarity of enterocytes and markedly atypical nuclei. Other parts of the tumor display a progression into invasive intramucosal adenocarcinoma with cribriform pattern of growth. Serrated polyps represent a group of lesions defined by a characteristic saw-like relief of crypts. The most common subtype is a hyperplastic polyp, constituting more than 80% of all serrated polyps. The rest is represented by serrated adenomas, including sessile serrated adenomas and traditional serrated adenomas. For a long time, hyperplastic polyps were considered to be non-neoplastic polypoid elevations of the mucosa, caused by reactive hyperplasia of the crypt epithelium as a consequence of a long-term irritation, for example, chronic inflammation. This theory might be correct for some localizations, for example, a stomach, but in intestines, situation is more complex. Hyperplastic intestinal polyps are in fact caused by hypermaturation of the epithelium due to a block of apoptosis. A physiological renewal of the epithelium is restrained, and the epithelia accumulate in crypts and gain a serrated appearance. They are probably not true neoplasms, but at least part of them may represent precursors of serrated adenomas, which already have a neoplastic nature. Grossly, they are smaller, inconspicuous, just a few millimeters big. Microscopically, crypts show a saw-like appearance of the epithelium and narrow towards the base. Dysplasia is not present. If hyperplastic polyps are multiple, they may be a sign of hyperplastic polyposis syndrome, with a risk of malignant transformation. Sessile serrated adenomas are similar to hyperplastic polyps, but they are larger, usually localized in the right-sided colon, and their crypts are not only serrated, but their basal parts are characteristically dilated and angulated into shape of a letter T or L. Dysplasia is usually not present, therefore a term sessile serrated lesion or polyp is sometimes used. However, despite the presence or absence of dysplasia, those lesions are true neoplasms with a risk of malignant transformation. Eventual presence of dysplasia is a sign of progression. The rarest subtype of serrated lesions is so-called traditional serrated adenoma. It's usually sessile, localized in a right-sided colon, and its relief is villous. Crypts are by definition serrated, but the cytoplasm of the enterocytes is homogeneously eosinophilic, not pale, because it contains almost no mucus. There is almost always a certain level of cellular irregularity, but it's still not sure if it should be classified as a dysplasia or not. Mural polyps are represented mainly by mesenchymal tumors. They are located not in the mucosa, but intramurally, in deeper levels of the intestinal wall, and the intact mucosa above is simply lifted. A submucosal lipoma is the most common example. A typical localization is the right-sided colon. It's necessary to keep in mind that in the region of the ileocecal valve, a presence of submucosal adipose tissue is physiological.